On behalf of Screen and J and Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And now I just have a few announcements before we begin the presentation. So this is just a quick disclaimer that the information contained in this presentation is not substitute for a medical consultation, and a physician should always be consulted for any health problem or medical condition. Today's agenda, so we're going to do a Project Echo series overview, introductions, the actual presentation, a case study, questions and answers, and if you stay at the end, we're going to have Dr. Evelyn Arana come and talk about her study. So a little bit about Project Echo. The Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. This is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case based learning to master complexity, and evaluating and monitoring outcomes. For more information on Project ECHO, you can visit echo.unm.edu. All right, so we'll do introductions now. So I will be doing the presentation. So hi, everyone. My name is Sarah Mehta. I am a passionate health professional with an extensive background in health education, health disparities, and a foundational base in global public health. I'm currently a community cancer control specialist at Rutgers Cancer Institute. In this role, I focus on cancer prevention education, screening awareness, and community engagement. Along with this role, I'm a graduate student at the School of Public Health at Rutgers University, and I am expecting to graduate this month. Austin Moriel, who will be doing the case study. Austin Moriel and his wife live in Highland Park, New Jersey, with their deaf pit bull, Poe. They have two daughters, both in college. In addition to working at the New Jersey Interfaith Center for Cancer Care, Austin also works for two other small community nonprofit programs, Neighbor Corpse Reentry Services and Who is My Neighbor Incorporated. But when he's not at work, Austin's pursuing his master's degree in English with a creative writing concentration at Monmouth University. And if he did have free time, Austin would be spending it metal detecting, reading, writing, or watching movies with his wife. Austin was diagnosed with cancer in 2010 and again in 2015 and is an advocate for accessible cancer screenings and healthcare for marginalized populations with a focus on the LGBTQ community. So without further ado, this is the intro to health disparities in the LGBTQIA plus community. So while this space remains a judgment-free zone for learning and growth, I want to encourage us all to take a step beyond that. Let's make this a brave space where people can engage in honesty and vulnerability. This means not just listening, but also speaking up if you have questions or perspectives, even if they're challenging or uncomfortable. Let's lean into this respectful dialogue, embrace discomfort as part of growth, and support one another in speaking our truths, because together we can build an understanding and deepen our learning by being both brave and compassionate. So please feel free to speak up with any questions or comments that you have at any time. You can type them in the chat, you can unmute your mic, and if you want your question or comment to be anonymous, you can send it privately to me or Evelyn, and we can read it without revealing your name. And if you have any questions, my email will be provided, and you can reach out to me in Austin on our Mighty Networks as well. So these are the objectives for today. So we're going to go over some terminology, some concepts, understand LGBTQIA health disparities and barriers to care. We're going to learn how to create a safe and affirming environment and explore some resources, both local, national, and state. So I have a pre-test that I forgot that I had, but we can do it in the chat because I don't think we have it set up. So you can just put the answer that you think it is in the chat, and then we're going to go over it at the end of the entire presentation. So the first question is, what does the LGBTQIA acronym stand for? The second question, HPV is known to cause cancer, true or false? And then the third question, LGBTQIA populations have the highest rates of tobacco, alcohol, and other drug use. I'll give you guys a second to put your answers in the chat. All right, so now we're going to cover some terminology because I think it's important to understand the basic terms and concepts if we're going to understand the health disparities and barriers. So this is the acronym LGBTQIA plus. The first letter of the acronym is L, which stands for lesbian, and the term lesbian is used to describe a person who identifies as a woman who is romantically or sexually attracted to other women. The second letter of the acronym is G, which stands for gay, and the term gay is used to describe someone who is attracted to members of the same gender. So, most of the time, the word gay is used to describe men who like other men, but it can also be used to describe women who like other women. The third letter is B, which stands for bisexual. Bisexual describes someone who is either romantically or sexually attracted to both men and women. Transgender, which is the fourth letter of the acronym, and it is T, yeah. And this term basically describes someone who does not identify with the sex they were assigned at birth. So, transitioning can be medical, which is hormone surgeries. It can be social, changing names and pronouns, or even legal, like updating documents. Each person's journey is unique, and not everyone may pursue the same aspect. The fifth letter of the acronym is Q, which stands for queer. Queer is an umbrella term for anyone who is not straight or cisgendered. And this is just a reminder, cisgender refers to people whose gender identity matches their sex assigned at birth. So, an example, someone who was assigned female at birth and identifies as a woman is a cisgender woman. And queer was historically used as a slur, but many have reclaimed it as a positive, inclusive identifier. So the I refers to intersex. Intersex refers to individuals whose reproductive or sexual anatomy doesn't fit the typical definitions of male or female. This can involve a variation in chromosomes, hormones, or physical traits that don't align with the standard expectation of male or female bodies. And the correct and respectful term to use is intersex. Using the right language is so important because it creates a more inclusive environment. So when you're discussing or addressing someone who identifies as intersex, make sure to use this term that they're comfortable with and avoid older, inaccurate terms. And then the last letter of the acronym is A, and that stands for asexual. Asexuality refers to someone who experiences little to no sexual attraction to others. It's important to understand that asexuality exists on a spectrum. Some people might never feel sexual attraction, while others may experience it under certain conditions or with specific people. Being asexual doesn't necessarily mean someone doesn't want romantic relationships. Many asexual people do have fulfilling romantic partnerships. It just means that sexual attraction isn't a part of their experience or it plays a much smaller role than it might for others. So, beyond the acronym, the plus sign is used to describe any orientation or expression not listed in the LGBTQIA acronym. The plus is just basically there to acknowledge that sexual orientation and gender identity are diverse, fluid, and can't always be neatly captured in just a few letters. Each person has the right to define themselves in the ways that make sense to them, and it's our role to honor and respect it. So, some of the examples that I have on the screen are pansexual, which refers to someone who is attracted to people regardless of their gender, and genderqueer, someone who doesn't conform to traditional gender distinctions. So it's really important for us, especially as health professionals, to respect self-identification. When someone shares how they identify, we should listen attentively and use the terms that they prefer. Doing so is not just about being inclusive, it's also about recognizing their humanity and giving them the dignity of owning their identity. So, what is an LGBTQ plus ally? This term is used to describe someone who is actively supporting LGBTQ people. It encompasses straight and cisgender allies, as well as those within the LGBTQ community. So, now that I've gone over LGBTQ terminology and allyship, I want to focus on some other concepts. So, we're going to go over assigned sex, gender, and sexual orientation. So, what's the difference? So, sex assigned at birth is a label that you're given at birth based on medical factors, including your hormones, chromosomes, and genitals. So, most people are assigned male or female, and this is what's put on your birth certificate. But gender is the innermost concept of self as a man or woman, a blend of both or neither. One's gender identity can be the same or different than their sex assigned at birth. And then sexual orientation describes who you're attracted to romantically or sexually, and it is a spectrum, so it can vary through someone's life. I also wanted to include some anti-LGBTQ discrimination, just so we're clear on it. And also, I'm going to go over microaggressions in the next slide as well. But homophobia is the fear, hatred, discomfort, or a mistrust of those who identify as gay or lesbian. Biphobia is the fear, hatred, discomfort, or mistrust of those who identify as bisexual. And transphobia is the fear, hatred, discomfort of those who identify as transgender, genderqueer, or just don't fit traditional gender norms. Microaggressions are brief and commonplace daily verbal, behavioral, or environmental actions, and whether intentional or unintentional, they communicate hostile, derogatory, or negative ideas and insults towards members of an oppressed or targeted group. So, in the next slide, I have some examples of microaggressions within the LGBTQ community. So, like for example, telling somebody that's so gay, or you're really pretty for a lesbian, or who's the man or woman in your relationship. These are all microaggressions. So we're going to go over health disparities in the LGBTQ plus community, but let's first define what a health disparity is. So Healthy People 2020 describe it as a health difference linked to social, economic, or environmental disadvantage. And the CDC also adds to that, saying it's a preventable difference in disease or injury burden. These disparities often affect groups who face barriers due to factors like race, gender, sexual orientation, disability. And in the next section, we're going to look at key health disparities within this population and the factors behind them to better understand and address these challenges. But before we do that, I want to ask you guys, why do you think that the LGBTQIA plus population experiences higher health disparities compared to the general population? Feel free to unmute, type it in the chat.
I think it's because people don't fully understand the LGBTQIA plus community fully. They're not educated on it, they don't have trainings on it, and they don't know how to address this population when it comes to them trying to address health concerns they may have.
Totally agree. That's why it's so important that you guys are here today. Like this, thank you for being here and like taking the time out of your busy schedules to learn this or to go over this. I'm sure most of you know this anyway.
And Sarah, in the chat, we have discrimination, lack of provider education on LGBTQ specific issues, and fear to be misunderstood.
Thank you. I can't see the chat right now. Thank you. Okay. If nobody wants to add anything, we can move on. So, an overview of the health disparities faced by the LGBTQIA plus population. Important to recognize that these are often the result of systemic factors like discrimination, lack of access to care, and social stigma. But we're going to go more into that into the next slide. Right now, these are the key statistics. So, we can read through a few of them. LGBTQIA plus youth are 2 to 3 times more likely to attempt suicide. The same group of youth are likely to be homeless. Lesbians are less likely to get preventative services for cancer. Gay men are at higher risk of HIV and other STDs, especially among communities of color. There are also high rates of violence against this community. I'm sure you guys know the last bullet point, but LGBTQIA plus individuals, especially transgender people and people of color, face high rates of violence, and this includes physical assault, harassment, and even homicide. So why do these disparities exist? So these are a few of the reasons. So there's discrimination. I know someone said that in the chat from family, peers, medical community, and other services, the lack of health insurance, low levels of cultural competency from healthcare providers, the lack of appropriate social services and programs tailored to the community, bullying in schools, the lack of laws preventing bullying, a lack of safe spaces or social spaces, fear due to stigma, discrimination, and bias. And we're going to go over this one, but the tobacco industry targeting this community, inconsistent collection of sexual orientation and gender identity data in surveys and health records. So now let's take a closer look at one of the health disparities that I mentioned, which is tobacco use. So research on health disparities among the LGBTQ population is growing, but we still have like limited national data on tobacco use within this population. So I'll let you guys read the statistics below, and then we can go over why this disparity is occurring. So tobacco companies have employed various strategies to target the LGBTQ plus community. So this includes advertising in LGBTQ plus publications portraying tobacco as a normalized part of their daily routine. Also, like bars will host LGBTQ bar nights, like they use community outreach efforts, and they'll have sponsors from e-cigarette brands, vaping companies. And you can even see in this ad, like see the rainbows that they're having at the bottom. They are specifically targeting this community.
Can I say something about this?
Yes.
I went to a different state. I went to Colorado on a vacation, and there were all the bars were promoting like LGBTQ, like that whole community. Like they were like, oh, like we have, because I'm an out of towner, so like I was asking questions and stuff, and they were like, oh, um, yeah, we have a specific night that's dedicated to just that community that we do different things and that we normally wouldn't do on a regular day. And I thought that was I just thought it was weird. Like, I don't know, like, why do you need to say that to me? Like, I don't need to know, like, okay. But I just thought it was really, really odd that they came out and
Yeah.
just said that, like, out to just a random person. So, but yeah, it's a real thing. I saw it
Yeah.
with my own eyes. It was very, very interesting.
Thank you for sharing. Yeah. It is a very real, and you probably wouldn't even like, I probably wouldn't glance twice at it, but now I'm like, wait, they're targeting this community because they know. All right, so let's talk about HIV in the LGBTQ plus community. HIV is a virus that weakens the immune system, making people more vulnerable to infections. It spreads through contact with certain bodily fluids, most often during unprotected sex or by sharing needles. And if it's left untreated, it can progress to AIDS. And while anyone can get HIV, some groups including LGBTQ plus individuals, are at higher risk due to risk behaviors like IV drug use. LGBTQ people also face barriers to preventative care, making it less likely that they'll access HIV prevention tools like PrEP or early treatment. Another major disparity that we see in the queer community is a high burden of HPV infections. So, HPV is the most common STI and viral infection. And while many cases can clear on their own, some strains lead to warts or lead to cancer if they're left untreated. So, genital HPV spreads through skin to skin contact, making all sexually active LGBTQ individuals at risk. It transmits more easily on irritated skin, so often from penetrative sex. But people with weakened immune systems, like HIV positive, gay, or bisexual men, are more likely to develop severe HPV related diseases. HPV can also cause several types of cancer, including cervical, anal, or oral, which disproportionately affect the LGBTQ community. Many queer women skip screenings, mistakenly thinking that they're not at risk. However, HPV can spread through genital contact, shared sex toys, or touch, regardless of gender and regardless of the partner. So health disparities, we're going to talk about cancer now. So there's no biological reason for LGBTQ plus people to develop cancer at higher rates, but there are social barriers and other social factors that contribute to the queer population being diagnosed at higher rates or at later stages of the disease. And this is common not only with just cancer, like also other chronic diseases. But these disparities exist not only in rates and stages of diagnosis, but they also exist in treatment, recovery, and survivorship. So the social determinants of health. So LGBTQ plus individuals face many barriers rooted in the social determinants of health. So things like economic status, environment, discrimination. These disparities stem from systemic issues like legal discrimination, lack of protection, limited access to culturally competent care, and fewer social supports. I put this the square, it says a lack of provider knowledge worsens the issue. So 60% of oncologists feel unprepared to treat lesbian, gay, bisexual patients, and 80% feel unprepared to treat transgender patients. So some best practices. So a lot of this is for like registration forms, like because I am a community health worker. So, but like this one for names and pronouns, asking what is your preferred name, your legal name, asking what your pronouns are. Similarly, on this page, what's your current gender identity, um, your relationship status, the do's and the don'ts of the registration process. So avoid using gendered greetings over the phone, email, or in person. Use their full name, avoid prefixes, and don't assume pronouns based on their voice. Respect boundaries. Only ask relevant questions. Also, having a non-discrimination policy. So show this LGBTQ inclusive non-discrimination policy on the bottom of your emails, on the walls, in handouts, in high traffic areas on your website. Something else you can do is state your pronouns after your name and your email because it sends a clear signal to your patients of your program's value. Also, like having the sticker and the LGBTQ flag and a sticker around like your organization on the website even. And I know a lot of the information about the health disparities can seem very discouraging and just like hard to hear, but we're going to go over some resources all across New Jersey. Um, and these are the resources for tobacco cessation because LGBTQ plus individuals do use tobacco at higher rates and heavily because of targeted advertising, societal pressures, and stress. All of these services are free, and I know I'm going through these kind of fast, but all of these will be posted in our Mighty Networks. So if you want access to all of these, feel free to hop on over there. I think the link will be put at the end, but all of these will be posted there. And as we spoke before too, LGBTQ plus individuals are less likely to seek preventative care. And this is partly because of fear of discrimination or a lack of culturally competent providers. So here are a few services in New Jersey that offer primary care and other health services specifically for the LGBTQ population. And these are local, state, and national resources. They offer various services, advocacy, and support groups. And once again, all of this will be posted in the Mighty Networks. So now we're going to move on to the case study done by Austin. Austin, whenever you're ready, and you can tell me when to switch the slides.
Sure. Hi, everybody. Thank you very much for taking your time out of the day, like Sarah already said, for being here with us. My name is Austin Moriel. I'm a transgender man. Do not come from the medical field. I would like to make that disclaimer. So when I speak, it's speaking from lived experience as a transgender, former butch lesbian, current transgender man, and a two-time cancer survivor. And before I always say another disclaimer, whether I'm talking about my cancer story, whether I'm talking about my transition story. And when I am talking, I'm always speaking about my experience. I would never claim to speak for the community as a whole. My experience does not represent every trans man's experience. It's my individual experience. And the next thing is, I just want to say, some of you, most of you, I'm just meeting today. Um, and I'm going to be talking about a couple of things that I would never talk to strangers about, right? The first time I meet them. But in order to tell my cancer story, I might have to share a little bit too much information. So just putting that out there. And you can switch slides now, Sarah. So I was living in Atlanta. I lived in Atlanta from 1996 to 2010. Um, and I came out as gay sometime in my early 20s and didn't come out as transgender until I think I was probably 38. Um, and I was, as Sarah had mentioned, there are different ways to transition. I initially started socially um, by just going by my middle name, Austin, with certain people, and then using he, him pronouns. And then I got on testosterone, and then I finally had scheduled top surgery, which is basically a bilateral mastectomy. Um, and things were going well for me until the fall and early winter of 2009. Um, I had always had, well, not at a certain point in my life, I started having heavy periods and bad cramps, but that was just my normal. And then at this time period, fall and early winter 2009, my periods got incredibly heavy and my cramps got incredibly painful. I was not insured at the time. I was working full time, but I was uninsured because the place I worked at was so small that they didn't have to provide insurance, and the Obamacare wasn't a thing yet. Um, so I didn't have a primary care physician at the time, but finally I said to myself, this is just not normal. So I I did not have a primary care physician out of, as we talked earlier, out of fear of discrimination and, being misunderstood and discomfort with certain body parts. But I said, I think I should really find a primary care physician. So I actually interviewed a handful of primary care physicians. And found one who I was comfortable with. It was a gay practice. I said, this is the great place. However, because I was uninsured, I could not utilize them as much as I would like to because I couldn't pay the out of pocket expense. But they were able to direct me or write scripts for me to go see a specialist. Two specialists. The first specialist was, I believe, I can't remember if she was an endocrinologist or a hematologist, but because of the bleeding, she diagnosed me after a very cursory verbal examination as having pernicious anemia, wrote me a script for B12 injections, and sent me on my way. The other script my primary care physician wrote was for a an ultrasound, interior, exterior as well as interior. When I had that ultrasound, I and here's where the too much information comes. I had never had heterosexual sex. I also had never had penetrative sex. I was not comfortable with that. So I was talking to the tech and I mentioned, hey, I'm a butch lesbian. I've, never had heterosexual sex. I'm not used to penetration. I just wanted you to know this before you did the pelvic ultrasound. And she did not do the pelvic ultrasound because of that. I only had the exterior ultrasound done. Um, I 100% believe that had she done the pelvic ultrasound, that my story would have been very, very different. Um, upon the just doing the abdominal ultrasound, there was nothing concerning. So I just continued on with my mystery symptoms. And it was at that point that I started going to a community clinic in Atlanta. It used to be called the Feminist Women's Health Center. And they were, in addition to, serving all the women of Atlanta who wanted help, they were focused on the LGBTQ plus community, and they operated on a incredibly reasonable sliding scale basis. Um, and I was able to go there and have further exams and tons of blood work done. And it was at this community clinic that they realized that my blood counts were beginning to get lower and lower and lower, and that I should definitely find a way to, without insurance, to really, get some help. And if it weren't for this community clinic in Atlanta, I feel that I probably would, without exaggeration, would be dead right now, or just dead. And that is why I think organizations, whether it's a community clinic, whether it's a group like Screen NJ, whether it's Cancer Institute of New Jersey, that actually focuses on the LGBTQ plus community and creates awareness about the need for cancer screenings and provides a welcoming, warm welcome to the community. They're so important. And I was just fortunate to have the Feminist Women's Health Center in Atlanta. As 2009 wore on and my symptoms continued to wear on, I had a top surgery scheduled for October, and I got a call a couple of weeks before the surgery was scheduled, and the the person on the other end of the phone simply said, "There's absolutely no way we can do your surgery. Your pre-op blood work came back, and your blood counts are way too messed up, especially your platelet count." And so something that I had been looking forward to for so long, and I had done a fundraiser, and I was so focused on having my top surgery, I had to cancel it. I continued on testosterone while still having these mystery symptoms that nobody could seem to figure out what was going on with me. Next slide. And that all changed on the weekend, Martin Luther King Day weekend in 2010. I woke up and could not see out of one of my eyes. There was just this big blob floating around my right eye. And I had been having trouble breathing, shortness of breath. But on that particular day, the shortness of breath was so severe, coupled with this inability to see out of my right eye, that I called a friend and asked to finally go to the ER. I was uninsured, as I've mentioned, so I went to a hospital in Atlanta called Grady Hospital. And at the time, nobody wanted to go to Grady Hospital because it was in downtown Atlanta, and in 2010, downtown Atlanta was not a thriving area of town like it is now. And Grady was the hospital for the indigent and the unhoused. But I said, you know what? Get me down there, because I know they'll take me, and they'll help me. And even if I had gone to a private hospital, I probably would have ended up being sent to Grady anyway. So I got to Grady, presenting with the shortness of breath, with this blob in my eye. And they did some blood work, and my platelets were down to 14,000, where typical platelets are in a range of 140,000 to 400,000. And they said, "You are so lucky you came in. You could have been in an accident and easily bled to death." They tried stabilizing me in the emergency room. They started infusions. They did ultrasounds, CAT scans, everything they could possibly do to try to figure out what was going on with me. And then they sent me to the hospital, admitted me to the hospital where I stayed for, I think I was about a week or so that time. At no time during this period did anybody mention the word cancer. So cancer was not really on my radar. They attempted to do a bone marrow biopsy while I was in Grady the first time in my hospital room, which I thought was a little odd. And it did not go well. And he said, the hematologist said, let's do this when we'll have you come back and we'll do an X-ray assisted uh, uh, bone marrow biopsy. When I'd been admitted to my room at the hospital because of that blob in my eye, which by the end of after being in the emergency room for I think it was over 12 hours, I had completely forgotten about the blob. I had been admitted to my room, and it was probably about 11 o'clock at night, and I was sitting on the toilet, because I had so much fluids in me, I really needed to use the restroom, and I heard my door to my room open, and the door to the restroom open, and a med student was standing there, with I can't remember what the piece of equipment that the eye doctors use to look at your eyes, but she said, "Hi, I hear you're having trouble with your vision," and she starts trying to examine my eye while I'm on the toilet, urinating, while I'm surrounded by my IV poles and my blood transfusion poles, and I just looked at her and I said, "You've got to be kidding me. You're really doing this now?" And she said, "Yes, I am." And I said, Please, no, please just leave." And thank God she left, because I tend to think I'm a very patient person, but that was not the time for an eye exam. Like I said, they kept me in the hospital trying to figure out what was going on with me for about 10 days or so, and then discharged me. Um, During the in-between period, I had a series of appointments with their gynecology department. I had DNCs, I had pap smears, you name it, they did it to me. I had a bone marrow biopsy that was successful because it was X-ray assisted. And this time the doctor could actually find my the bone he needed. And they ended up diagnosing me with a rare blood condition called aplastic anemia. At the time, I think 1 in a million people got it. Basically, my bone marrow was no longer producing blood cells, and blood cells that were being produced were eating other blood cells. Again, at this time, still up to this day, with the aplastic anemia diagnosis, there was no mention of cancer. So the treatment for aplastic anemia is either a bone marrow transplant, for which I didn't qualify because of my age and because of the number of blood and platelet transfusions I had received. So the treatment was called ATG treatment, where I would be hospitalized for 3 months and receive a series of either horse or rabbit antibodies, which would cause my immune system to get recharged. But it was a 3 month hospitalization. So I quote unquote checked into Grady for that 3 month stay. And the day I checked in, I was supposed to start my treatment the next day. A med student came in and he sat down in the room, and I'm there all by myself. My family is in Nashville. My then girlfriend, now wife, is up here in New Jersey. Um, and the med student's talking, about the aplastic anemia treatment. And then he says, "Oh, and while you're here, be sure you talk with your gynecological team, because I saw that cancerous, result on that last test you had done, and you should really get that checked out since you'll be here for a while." And I think my face must have registered just abject shock and probably some horror, because he quickly grabbed his clipboard and got his pens and papers and walked out of the room, leaving me sitting there with the news that in addition to aplastic anemia, I also had cancer that no one had told me about. And so what does one do? One gets on the phone and Googles. And I quickly learned that one cannot be treated for aplastic anemia and cancer at the same time because the treatment will, for one, will exacerbate the condition for the other. So I'm sitting in the room by myself, just kind of staring out the window. And then my surgeon finally came in and she said, Austin, we need to talk. And I cut her off and said, oh, you mean about the cancer diagnosis? And this time her eyes got huge. And she said, how do you know? And I explained the delivery of the diagnosis that I'd received. And, she profusely apologized. And then we launched into prepping me for a complete hysterectomy. So I spent a couple of days just being filled with new blood and new platelets, and had my hysterectomy, and it ended up being stage 3C uterine cancer. Um, Nobody knew what to do with me as they tried to figure out the balance between the aplastic anemia and the cancer. And then one night, the oncologist came in. There were two of them. I affectionately call them the angels of death because the lead oncologist said that you'll need to told me I would need to decide between having chemotherapy or radiation. And she said, and I quote, the chemotherapy will extend your life, but you'll be so incredibly sick that you'll feel miserable for long and more intensely than you normally would because your system is so depleted. The radiation will be so much easier on your body, but you'll have a much shorter lifespan. So you need to make a decision between length of life and quality of life. And we'll be back tomorrow morning at 8 a.m. for your decision. And then she and her partner walked out the door. And so for the second time, I was left there alone with facing this news. And that's really the first time I just sobbed. Luckily, one of the med students came in shortly thereafter with whom I'd gotten along with well, and she talked me off of my literal ledge because I was looking out that window at one point, seeing how high the room was. But I was not ready for that delivery of that news, and for it to be presented that way. Luckily, my hematologist said, "Stay away from them. Stay away from the oncologists." And we worked up a plan with Dr. Diaz, who was the radiation oncologist. He developed a specific treatment plan just for me that would preserve my pelvic bone, because that's where the factory is that's making all those, the blood cells. And really it would, hopefully take care of the cancer while preserving my factory for blood cells. And it seems to be working because at the time he had told me, your expectancy is 6 years, and that was in 2010, and it's now 2025. So whatever he did with his treatment plan, it worked. And in the follow-up to my surgery, and I never had the aplastic anemia treatment. I just kept seeing my hematologist and having blood work done on a regular basis. I was supposed to be moving up to New Jersey in August of 2010, but I was hesitant to do so because I didn't want to leave my radiation team or my hematology team. And my hematologist, he said, Austin, go. Please go. He said, yes, your blood counts are not the greatest, but they're not the worst. He said, I treat people, I don't treat numbers. And by the way, they have doctors in New Jersey. I was like, oh yeah, you're right. And he actually gave me some referrals. And so I packed up my apartment and my dogs and headed up here. At this point, not really knowing if the cancer was completely gone, because I had stopped the internal radiation one treatment early, because I was a wimp and couldn't take it anymore. And the only way for them to know if the cancer was really gone, since I was stage 3C and it was in my lymph nodes, would have been for me to have a PET scan, and my insurance would obviously, well, lack of insurance, there was no way I could get that. Next slide, please. And so for in my case, there were a few factors that led to my cancer. Genetics. Cancer was rampant on my mother's side of the family. On the females in her side of the family. I am 100% that played a part. Um, Another huge factor is on me, that I really wanted to see myself reflected in medical providers, but it was very hard for me to find a butch primary care physician at the time. And I had to, talk to myself and not lower my expectations, but adjust my expectations and say, okay, you might not find yourself exactly represented in your doctor, but you can at least find members of the community in your healthcare team. But I am sure if I had done that earlier, it would have been caught earlier. And I would have been getting screenings. And as Sarah talked about the behaviors, social behaviors, social risk factors, drinking and smoking was rampant, rampant. Bars play such a central figure in the queer community as gathering places that the drinking and smoking, it was just, it was second nature. To go out and drink, smoke, or to go over to friends' houses and drink and smoke. So I definitely think that was kind of the trifecta that led to my diagnosis. Next slide. And so throughout my experience, both down in Atlanta and also when I was diagnosed again up here, I was, especially when I was in Atlanta, I was misgendered left and right because I had just started testosterone. So I didn't have much facial hair. I had not had my surgery yet. So I had size double D breasts. So, and I understood that it was difficult for people to see me, this presentation, and then hear me say, I'd like to be called he, him. I'd like to go by my middle name. And while I understand that was difficult, I also understood that I deserved that respect from my care team. So when it comes to, suggestions for medical professionals, for social workers, for anybody who's interacting with the queer community, gender references, pronouns, chosen names are so important. Whether it's in face-to-face interactions or in medical records. I've recently had need to look through old medical records, and in my hospital records, I am in one paragraph, it goes from he to she, he to she, he to she, like bouncing back and forth. And I'm like, at least just pick one and stick with it. There's no consistency whatsoever, and definitely wasn't consistency in using the pronoun that I had chosen to use. There was also just widespread misuse of terminology. I was repeatedly called or referred to as a transgender woman in my notes, in the hospital notes, which I am not. Or I was referred to as transgendered, which is not a thing. And of course I didn't know that at the time, but going back, these years later and seeing that, there's the knowledge is out there. People just need to pay attention to the information to have their medical records truly reflect their experience. I suggest the reading of the chart. I was in 2015 for my second diagnosis. I had a carcinoma on my eyelid that I had to go to Philadelphia to have removed at the Wills Eye Hospital. And by this point, I was medically transitioned, full beard, I had top surgery, and I was getting ready to go have my eyelid resectioned, and I mentioned my uterine cancer to one of the nurses who was prepping me, and another one of the nurses, he just started laughing, and he's like, "Oh, that's a good one, uterine cancer." Yeah, and his coworker looked at him and said, kind of smacked him and said, "What are you doing?" She was like, "He's a transgender male," and kind of schooled this guy for not having done his, quick homework, know the patient that he was going to be interacting with. Another thing that is huge is learning the resources in the area, to be able to recommend if you are working with someone who's from the queer community, not just medical resources, but mental health resources, social opportunities, career networking, anything that's going to really contribute to the holistic overall well-being of that person. Um, Sarah mentioned including signage, and that states your policy, as well as maybe a little rainbow flag here and there. But one of the things I've noticed is that there tends to be gender inclusive decor in different types of clinics. I had to have a series of mammograms over the past couple of years, and I have never felt more out of place than I did walking into the breast clinic at Somerset Hospital. Uh, the staff was absolutely amazing and never made me feel uncomfortable. But boy, just based upon an aesthetic of the clinic and the signage in the clinic, did I feel like I did not belong. And there are ways to have decor that's gender inclusive or gender neutral, to make everybody feel welcome. But the main suggestion is just don't be a jerk. Um, you know, there I've worked with people who purposely misgendered me in front of other people who had no idea that I was transgender. And they were just being a jerk. They were not like my dad used to be, and they weren't making honest mistakes. They were being jerks. Um, there was a nurse when I went in for I can't even remember what appointment. I hadn't changed my name legally yet, so I still had my legal first name of Mara, Mara. And we were going, she was doing the questions at the beginning of the appointment, and she said, "Oh, Mara, that's such a cool name." And I was like, "Yeah, it's my legal name. I haven't had it changed yet." And she's like, "Well, why would you get it changed?" I was like, "Well, because it's, I'm transgender." And she was like, "Oh," she said, "I thought it was just a cool, a cool, unusual male name." Whether she really thought that or not, I have no idea, but she played it off like she did, and it made me feel great. There wasn't any judgment, there wasn't any, feeling of, discrimination. And like I said, I'd like to think that she really, really did feel that. And then patient self-advocacy, I think is huge. It's difficult, but huge. I mentioned that I interviewed my doctors in Atlanta to find somebody I was comfortable with. And I would recommend to anyone in the queer community, if they don't have a primary care physician that they're comfortable with, to ask around, to get recommendations, to, to like I said, to interview and find someone they're comfortable with. Doesn't mean they're necessarily going to be going to a queer medical professional, but they can at least try to make sure they're going to an allied medical professional. I've been lucky in my healthcare team up here in Atlanta or in New Jersey now. Every one of them is a member of the queer community, and my primary care physician knows that if I need to be referred to another specialist to focus on finding a professional who's in the community. Of course, she's not going to sacrifice quality of care for that, but she is going to put the time in to find somebody that I'm comfortable with. And I think that is just so important. The responsibility obviously shouldn't be on the patient for the caregiver to make us feel comfortable, but I 100% believe that we can do things ourselves to make our experience more comfortable and a little bit smoother. And I that should be the last slide.
That was wonderful. Thank you so much, Austin, for sharing that. If anybody has any questions for you, they can put it in the chat, but also I'll do the Mighty Networks. I don't know if you want to share your email or anything, but Mighty Networks people can reach out to you directly too.
I'll put my email in right here.
Okay. Thank you so much for sharing that. Dr. Evelyn Arana, I believe you are here if you want to share a few words about your study that you're doing.
Yes, thank you. I also just want to share the flyer too, so people can see it. So I think, Sarah, you might need to give me permission to share the screen.
Okay.
Okay, here we go. Okay, can you all see this flyer? Can you all see this? Okay. So I know we only have 2 minutes, but that's really all I need. So I have a study. I'm an assistant professor at Rutgers Cancer Institute, and I do research primarily with Hispanic cancer survivors. But I have this study that just opened a couple of months ago specifically for LGBTQ Hispanic cancer patients and survivors. It's a needs assessment. It's completely virtual. It's one survey and one interview done over the phone or through Zoom. The purpose of the study is to, as Austin shared, a lot of barriers that he faced. We want to learn and understand the barriers to cancer care and survivorship care that Hispanic cancer survivors face. As you may know, Hispanic cancer survivors are very much underrepresented in basically all research areas. And so I'm interested in looking at the intersection of being LGBTQ plus and being Hispanic and how that can affect cancer care that these patients receive. So anyone who's 18 and older identifies as LGBTQIA, speaks Spanish or English. We're also doing this in Spanish. It's just a 45-minute discussion online, hearing your story. How was your experience with your cancer diagnosis, but also your survivorship experience if the patient has completed their cancer treatment. And then there's a survey that could be completed over the phone with someone on our team, which Arlette is on the call too. She's a research scientist on my team. And there is compensation for this. So for each survey and the interview, there's a $50 gift card compensation that we can give. So if anyone is interested, you can contact Arlette. She's on the call, but I'm also going to share the flyer in the chat so that whoever would like to, there it is, I think it just went through. Whoever would like to share the flyer or knows of someone who may be interested, please go ahead and share it.
Thank you for sharing that. I'll post that as well. I'm going to save it right now. And I think we just have a few wrap up things. So we'll forgo the pre-test, but if you have any questions, remember our Mighty Networks. And also NJC, everything will be in the chat for free breast, cervical, colorectal, prostate screenings. And thank you again for attending today's session. And thank you for everyone who participated in today's session. The QR code or the link for the evaluation is in the chat. So please let us know how we did. Our Mighty Networks link will be in the chat as well. And then in June, we're having a session on clinical trials. So make sure you register and come to that. And I believe that's all. Thank you so much.
Thank you.
Thank you.
Thank you, everybody.